and I've now got 20 minutes to talk to you about podcasting. So my name is Amie Burbridge. I'm a consultant in acute and general medicine in the United Kingdom. I work at the Royal College of Physicians at the UK. I'm a member of the European Federation of Internal Medicine as well, and I work at the local medical school. So I'm here to talk about podcasts and what is actually a podcast. Where does the term podcast come from? So a podcast is a portmanteau, which is basically a blended word of iPod, which comes from obviously Apple iPod, and a broadcast. So the first podcast ever was released in 2004. So podcasts have been around for around 18 years now. And particularly during the pandemic and post-pandemic, the utilisation of podcasts have grown exponentially. And what actually is a podcast? Well, a podcast is a series of spoken word. And it's a narrative, it's a story, it's a conversation between two or more people. We know that in the UK, more than 50% of the population listen to podcasts. In the US, it's around the same, and in Canada, around 30%, and in Poland, it's a little bit lower. So podcasts are huge, huge business. A podcast is an audio file that is downloaded. And it can be downloaded onto your phone, onto your computer. It can be downloaded via Apple, via Spotify, by Google Play. And here are some examples of some podcasts. Now, the podcast symbol in the middle is what you will have on your Apple phone when you have your podcast downloaded. The biggest podcast in the world is a podcast called Serial. It is an incredible podcast. It's an American podcast. And basically, it's about wrong convictions. And actually, this podcast has over 300 million downloads worldwide. The reach of podcasts is huge. And in fact, this podcast led to a complete change and a wrong conviction of somebody who was convicted of murder. It's massive. So if you imagine that the reach of this podcast was 300 million, what can the reach of a medical podcast do? So why am I here to talk about podcasts? So about 5 or 6 years ago, I was sitting my specialty exit exams to become a consultant. And I really struggle with reading textbooks. I really struggle with sitting down for any longer than 10 minutes, which is why I work in acute medicine. I like to be active. And I was thinking, how can I be active and learning at the same time? And there wasn't really much available. So I got my phone and I recorded myself talking about acute coronary syndrome. And then I listened back to it. And I was like, oh, I've got an idea here. Let's see if there's any medical podcasts out there. There wasn't. There were no British-based podcasts. So I was like, let's make one. Why not? So I went to the Royal College of Physicians and they said, no, nobody listens to podcasts. It's like, okay. So I kept going back. No, nobody listens to podcasts. I was like, do you know what? I really think they do. So a chance meeting with my co-presenter, Hussein, and we decided to just go ahead. And we decided to start recording a podcast. And that led to the Royal College of Physicians Medicine podcast. And it's still ongoing now. We are nearly at 1 million downloads worldwide. And the premise of this podcast is that we talk about cases that we've seen. Hussein is a trainee and I'm a consultant. And we discuss cases that we see on a day-to-day basis during on-calls. And we relate it back to the latest clinical guidelines and the latest evidence-based medicine. So it's always based on guidelines and evidence. And the good thing about podcasts, particularly education podcasts, is the reach is huge. So we can actually see what countries listen to the podcast. And we have people listening all over the world. And it's been incredibly useful in countries where they have poorer access to education. And also, for example, we've got a large number of listeners in the Ukraine now who are unable to access their regular education, and they are now starting to utilise podcasts. So after after I developed the RCP Medicine podcast, which is very much based around guidelines, one of the things that I think we struggle with in education to teach in medical education is clinical reasoning. How do I teach a trainee how to make decisions? There are no formal teaching sessions in the undergraduate curriculum in England on how we learn to make decisions and how we teach clinical reasoning. So I was trying to think of how we could teach clinical reasoning, and that's where the Home of Medicine came along. And the Home of Medicine is a podcast where I talk to another consultant or attending, and he presents a case to me that I know nothing about, or vice versa, and we talk through that case in real time. The really good premise of that is that listeners actually hear how we make decisions. We're actually verbalizing that decision-making process. And by doing that, we are helping the listener to develop an illness script, which is very difficult to do in the formal lecture-based setting. And also, it helps me talk about cognitive biases in clinical reasoning, which again is very difficult to get across sometimes in that traditional lecture. So, why are podcasts any good? Why is a podcast better than a lecture? So, when I was at medical school, all of my education was lecture-based. So we would start at 9 o'clock, we would sit down, and we would be there till 5 o'clock. And we would write notes, and we would fall asleep, and we would drift off. We didn't have mobile phones when I started medical school, so we didn't use our phones, but we just would daydream. And it just wasn't really an effective utilisation of time. And that's where the podcast comes in. Now, I know that there is a little bit of a shift away from traditional lectures, but it's still there. We are still utilising that traditional lecture, particularly in the UK. Lectures are still big business. But podcasts are great. They are accessible anywhere, any time. So if you're on a night shift and you've finished your night shift and you're driving home, instead of reading a book, do you know what? I'm going to listen to a 20-minute podcast, and I'm going to have the latest up-to-date information on how to manage atrial fibrillation, for example. They're really good if you've got other commitments. So if you've got family, if you do a lot of driving around, they are fantastic for being able to listen and learn at the same time as maybe doing the cooking, as maybe doing the gardening, as maybe putting the bins out. So they really can be utilised at any time, any place. What's also really good about podcasting is that they are very good for people who have neurodiversity, dyslexia, visual impairments. So the traditional lectures are very much geared towards neurotypical individuals who can sit and focus. But actually, the number of the population who can do that is actually quite low. We really need to start to broaden how we educate. We've talked about simulation, we've talked about YouTube, we've talked about videos. These are all ways in which we can target the neurodiverse, but also we've now got podcasting. And that's also another good way of making education accessible for all. Particularly in countries, as I've said, who are at war or who don't have as much money and don't have accessibility, this really makes education accessible to everyone, and it is really, really important. Now, the good thing about podcasts, you can listen to them when you feel like listening to them. You can listen to them in your own time. You can listen to them in isolation. If you know you've got a lecture coming up tomorrow on gastroesophageal reflux disease, you can listen to a podcast on gastroesophageal reflux disease before you go to the lecture. And when you're in the lecture, you don't spend the time learning new information. You spend the time actively participating in that lecture. And this is where we flip the classroom. This is where, during that lecture, we have debate, we have discussion, we have group participation, because the individual who's actually presenting no longer needs to spend 20 minutes describing the basic physiology, the investigations and management plan of gastroesophageal reflux disease, you've already listened to it. And it's about consolidating that learning. However, as well as listening before a lecture, you can listen after a lecture. So if you've missed something, if maybe the way that the lecture engaged you didn't suit you, if you were off sick, if you were very tired, then actually you can listen afterwards and still gain that information. You don't have to carry around massive textbooks, which I know, to be fair, not many people do anymore. But, you know, it's little things, practical things that podcasts can actually now do. I'm not saying that podcasts are going to replace lectures, but they're an adjunct. And I think that we need to utilise both lectures and podcasting and simulation and YouTube and all of these different varieties. And we really need to allow the learner to choose how they learn. Some people will find podcasts great, some people won't. But we really need to increase our options to how people really do learn. So, why are podcasts so special? Who in this room has listened to a podcast? Okay, so quite a big number. Who's listened to a medical podcast? So not as many. Okay, so probably about 50% of people in this room have listened to a medical podcast. So why are medical podcasts so special? There is very little research on podcasting in medicine, very little. And that is because they're quite new and it's quite difficult to get qualitative and quantitative data from listening to a podcast. So when I listen to a podcast, it's quite intimate. It's quite an intimate environment because I am having a conversation, I'm listening in my own time, and my brain is working at the pace of the audio. If I don't understand something in that podcast, I stop the podcast and I can make notes, I can rewind, and I can listen again. Whereas in a lecture, you can't do that. If you don't understand it, you don't understand it. And you have to move on. But in a podcast, for example, in the Hope of Medicine podcast, we talk about cases and we talk about differential diagnoses. So we ask the listener to pause and we ask the listener to stop and write down differential diagnoses. They then listen to the next section. We then stop and ask them to write down potential investigations. We then carry on and then ask them to think about potential management plans. And by doing this, we're engaging the listener actively, even though it is actually a passive form of learning. We then have Twitter debates. So after we release a podcast, we then go onto Twitter and we then have debates with our listeners about how or what we did wrong, what we did right, what would they have done differently. So we've got a community. So we are forming an educational community that wasn't there before. And this educational community is worldwide. Before, medical education was very much based at your medical school. It wasn't even based through the country. So if I went to medical school in Warwick, I didn't know anybody in London. But now we've really opened up that medical education community. I have people listening in Bhutan, Malaysia, India, Canada, all over the world who connect via Twitter. And it's really interesting to see different people's understanding and their take on things. So we've developed this whole new community that wasn't even there before. And that is incredibly special. Another fantastic thing about podcasts is we can get on world experts. Now, if you get a world expert to attend a lecture, you may have 200 people at that lecture who are going to take away that information. Now, we recorded a podcast in June of this year with a member of the Bedside Medicine Society. He works at Harvard Medical School and he's the president of the Royal College of Physicians in Scotland. And his specialty is bedside education. We were able to record that podcast, release it, and everybody was able to get that level of expertise all over the world. Whereas if it wasn't podcasted, very few people would have been able to have listened. So it's a really good way for transmitting really interesting, important data from world-renowned experts in a really easy, achievable format. And they're also free. You don't have to pay for podcasts. So these podcasts are all free. So money isn't an issue for the listener. It's an issue for me because I don't get paid and I do all this. And it can cost money for the development and the production of a podcast, but the listener, it's all free. So it's breaking down those barriers that are sometimes set by finances. People don't have to pay for them, which is incredible. Another thing that it's helped to do is flatten the hierarchy within medicine. So when I'm having a conversation with a professor of bedside medicine from Harvard Medical School, who I would never, ever have been able to meet previously, I'm having a face-to-face discussion. We're recording that podcast in a conversational manner. We're breaking down those barriers. We're making medical education accessible to all. No longer are professors, these people sitting in ivory towers, not educating. They're here. They're available. They're talking to us. And we're learning from them. And that is really, really special. Podcasts can also be used in interweaving storytelling, and they're immersive. Each podcast has a beginning, a middle, and an end. We're telling a story, and actually listening to a story is really interesting. When you're listening to somebody on a lectern talk about, I'm going to go back to gastroesophageal reflux disease, it's one way, there's no conversation, and actually it can be quite boring. But when you've got a two-way or a three-way narrative, a story, a patient is behind that narrative, it's happening in real time, we are actually verbalizing our thought processes. We are performing and developing that illness script. It's really, really engaging and really important. We know that by listening to podcasts, people don't just learn about the condition, but they also learn about empathy, about communication skills, about really immersing themselves in how that doctor feels. What we often do in podcasts is, at the beginning, we set the scene. We want that learner to be standing in the emergency department. We want them to be outside the patient room. We ask them to hold the notes. We ask them to open the notes and look at the ECG. We describe the ECG to them. We say that the ECG is in atrial fibrillation. The blood pressure of the patient is 100/70, but it's really noisy and you're finding it really difficult to concentrate. So we're really trying to immerse them in the actual clinical setting at the same time. It's a sort of simulation with a difference, because this simulation is accessible and it's free, and we can deliver it on a very, very big scale. So why should we be listening to podcasts? Why should everybody in this room start to listen to medical podcasts? And why should people in this room start to develop their own medical podcasts? You know, this medical school here could have their own podcast. You know, McMaster University could have their own podcast. This is how they could transmit really important information to a large group of people in a relatively easy way. So podcasts take people on a journey, and it's really important that that journey, that the podcast, that the listener is taken on, is evidence-based, that it's based on guidelines, and that, you know, anybody could do a podcast, but we have to make sure that it does have credibility. And that is why whenever we get speakers on the podcast, they have to be credible, because what you don't want to do is basically pass on poor information. We have to make sure that it is guideline-based, that it is evidence-based, and that is really, really important. So I want everybody who hasn't listened to a medical podcast to go away and see if it's beneficial for them. It may or may not be. And actually, what can lecturers learn from podcasts? So I'm not saying this is the end of lectures. You know, all of our different ways of educating are adjuncts to each other. But actually, we know that our ability to concentrate is 20 to 30 minutes. So should we shorten lectures? Should each lecture be 20 to 30 minutes? A lot of the success of podcasting is actually due to the presenters. And it's about how engaging they are. It's about their personality. It's about their charisma. And I know I've certainly sat in a lot of lectures where they're not educators, they are standing reading from slides. And actually, could we start to make lectures a little bit more immersive? Could we start to make them more engaging? And maybe we do need to start to change on how we teach, big scale. So is it time to completely flip the learning environment and utilise podcasts before people come to lectures? Should we start having the passive learning of lectures and encourage students to listen to the lecture, the podcast before they come to a lecture, and utilising that lecture for active participation? Let's have group discussions. Let's really think about how we can consolidate learning in lectures rather than just introducing new information at the very beginning. We all have this technology accessible. I bet everybody in this room has got a smartphone. So everybody in their hand has education at their fingertips 24 hours a day, but not everybody has access to lectures 24 hours a day. So let's start to think about how we can bring podcasting to the mainstream of medical education rather than just a specialist thing that a few people in medicine do. So what is the future? In the post-pandemic world, it has completely changed how we learn and how we educate. We all had to adapt so quickly into educating. And we went online, we used Zoom, we used Microsoft Teams. We really lost that connection with our learners. Podcasts, yes, it isn't face-to-face, but it is quite an intimate engagement with your listener, and the listener truly feels like they are listening to a conversation between two people rather than that podcast being listened to by 500,000 people. It really is very, very special. So how can we improve medical education for all? Yes, we need to start utilising podcasts. We need to use less paper. Let's think about the environment. The good thing about podcasting is it actually reduces our carbon footprint, and we're no longer printing out lots of paper and lots of lecture notes. So that also has an environmental impact as well. Podcasts don't necessarily as well just have to be used for medical students, but the general public. General public, we've had a lot of people actually comment and they actually like to listen to these podcasts. So should we start to do more podcasts for health education, the general population? We know that lifestyle medicine is so important. Why don't we start to talk about this on podcasts? Let's get this information out. So let's not just, think, okay, this is only for people at medical school. Anybody could listen to these podcasts. Let's make them for the general public. Let's really open health education, because one of the problems we've got post-pandemic is empowering people to take responsibility for their own health. Okay, if we make podcasts for the general public about health, we are giving them the information. They can listen to it when they want and how they want, and that is also a really important way of disseminating information. So this is a QR code. If you click on this QR code, it will take you to the Home of Medicine podcast. And that is a podcast that I do in association with the European Federation of Internal Medicine. I talk to lots and lots of different consultants, lots of different trainees, and we talk about clinical cases, we talk about clinical reasoning, and we talk about cognitive biases. Thank you very much. I think I'm just in time. So thank you very much.
Thank you very much, Dr. Burbridge. It says in your bio that you love to bring joy and spark educational activities, but that was a huge understatement. There are questions.
Okay.
For which I'm very grateful. You have addressed the quality of content in your presentation. Do you think there should be any sort of a review or sort of accreditation of podcasts?
So yeah, absolutely. So the Royal College of Physicians podcast that I do, every podcast episode that is recorded is then sent to the senior censors at the Royal College of Physicians who listen. So like 4 of them will listen to it and they will provide feedback. And these are the most senior people in the RCP in the UK. They will listen and they will say, that's wrong, this is right. If there's anything wrong, we re-record. So that's a way that we've addressed that for the RCP one. However, there is a lot of rubbish out there. And it is really difficult because, as I say, anybody can record a podcast. And I think a lot of it is about the learner themselves being able to identify what is good and what is bad. But absolutely, moving forward, medical podcasts need to be accredited either by a Royal College or by a medical school.
Yeah, well, some professional societies
Yeah.
could do their job, probably also.
Mm-hmm.
Now, there is a question which I find really interesting because it shows the difference. You said that podcasts are relatively new because they were established in 2004. I strongly agree with that, but the question is, the podcast technology is relatively old.
Mm-hmm.
Do you see any limitations that could be addressed with new technologies like augmented reality?
Yeah, absolutely. So you're right, podcast technology is still old, and actually the way that we record is still quite traditional. 2 people on a microphone, although we now do it online, which is pre-pandemic, weren't really aware of that. To be honest, I don't really know much about augmented reality. That's not my area of expertise. But the problem I think we've got with podcasting at the moment is there is not many people who understand the technology, and there's not the funding to develop them further. So a lot of the stuff I've done, it's by myself with no funding. And I've learned as I go. And, you know, definitely, I think we need societies, we need universities to take on board the educational benefit of podcasts, to really, really integrate them into medical schools and Royal colleges, and they should be part of the curriculum. They should be part of learning.
You have addressed the issue of the widespread of podcasts.
Yeah.
That you said that you've been listened to all over the world.
Yeah.
Do you know who your listeners are? How old they are?
No. So that's one thing we can't find out. And that is, again, another limitation of podcasting data. So when you have a podcast, you upload it onto Apple, Spotify, Google Play, and you get feedback. So I know how many listeners have listened in countries, when they listen, how long they listen. And I know even what towns and cities. But what I don't know is how old they are, because we don't have, unless the listener puts that information on, we aren't able to get it. The only way I know a little bit about the listeners is from what they've email or Twitter engagement.
And what's your take on it?
Does it matter?
Like
how old the listener is?
Yes, because, for example, if those are very junior people, the content should be adjusted somehow.
Yes.
If those are, consultant level, perhaps something different should be on those podcasts.
So this is certainly what we've addressed with the podcasts. And the initial RCP Medicine podcast was geared towards doctors in training. And actually, the feedback we were getting were medical students really, really liked them. So we adapted our content. So now the content builds throughout the podcast. So I will start off with quite basic physiology, and I will build that content up, and I will talk about investigations and management, and then we will also cover it from a consultant level. So we try and get the podcast to incorporate learners of all ages and all levels.
Any advice for countries where podcasting is not a thing?
Go for it. Honestly, it's so enjoyable, and you get so much engagement from it, and you learn yourself, because for me to make a podcast I have to also really understand that particular topic. You need a microphone, you need a computer, and you record it, and you then upload it to Buzzsprout, which is the one that's used all over the world to make podcasts. You do a little bit of editing, they help you with it, and then you publish it, and it's all free. And it's really, really easy to have a go. So do it.
I will try, although I have a question from myself now.
Yeah.
We know how much effort it does take to produce those surgical videos, because I'm on the other side, like the receiving end of your work in clinical practice, also a surgeon. how much time do you need to produce one 20-minute podcast?
Yeah, okay, it's a lot. So the preparation so I did a podcast last week on monkeypox. And to prepare for that 30-minute podcast, I had to make sure I read all the latest guidelines, being up to date with the latest BMJ article on monkeypox. I had to learn all about the vaccines. So the recording itself is really simple. The actual sitting down for 30 minutes, it's really easy. But the preliminary work, that can be 4 to 5 hours. Then the post-production work is also a couple of hours. So it is a huge amount of work that goes into it, actually. Yeah.
There is one question from Professor Janczuk.
It is more a comment, because you mentioned, you asked the question whether we should make lectures shorter.
Yeah.
And this is what we do. For my university, we don't have lectures face-to-face at all.
Oh,
Everything
okay.
available online. So this is sort of midway to the podcast. So our students can watch them whenever they like. And every semester they are updated.
Mm-hmm.
And then we encourage our teachers not to record a 2 hours long massive lecture on like heart pathology, but 20 minutes long. And I'm even showing them that Netflix serials are just like 25 minutes long.
Yeah.
So they chunk the lectures, and then such chunks of lectures are obligatory before the seminars. So we follow.
Yeah, that's fantastic. I mean, in the UK, we're a little bit behind, but I mean, there's definitely a way to go. So that's really interesting, actually.
So it's like video podcasting?
It's a VOD.
Well, it is just
like
as I said, we
TEDx.
update it every semester, so it's not produced
Yeah.
as frequently as podcasts.
Yeah.
Okay, Dr. Burbridge, thank you very
Thank you
much.
very much.